Good afternoon. So I am with the stand that wet lab is not needed for surgical training of residents. I will be defending my stand using 3 statements. Statement 1. What we usually do here now as young ophthalmologists is dry practice. There's a huge difference between wet lab and dry practice. What is dry practice? Practice of surgical steps in a sterile or unsterile area on dry objects that mimic texture of ocular tissue. Example, tunnel construction on IOL cardboard, capsulorhexis on plastic cover of IOL box. So it actually needs nothing separately. You can use the usual OT microscope. Separate instruments are not needed and no model eye is needed. This is the option that is available to most residents in our Indian setup. And this is what we started with. Whereas what is a wet lab? A wet lab is defined as a separate demarcated unsterile area for practice of various surgical steps on a model eye. It needs a separate microscope, it needs separate instruments, and it needs goat, pig, expired donor corneas or wax size. And most importantly, it needs money. This is what we all have done initially, and this is a wet lab. Most institutes in Indian setup cannot afford a separate wet lab. There's separate cost of microscope, instruments, and model eyes. Phaco and vitrectomy simulator costs goes in lakhs. Does this mean that our residents should not have hands-on? Not at all. I have used this traffic signal theory to kind of separate the surgical steps into red, orange, and green. Red is do not proceed without wet lab. In the sense, wet lab is definitely needed in these surgical steps. For example, nucleus management in phacoemulsification. For orange is dry practice and then perform under supervision. ECC suturing. After dry practice on foam, you can do it. Dry lab of tunnel construction in SICS, capsulorhexis, and suturing donor graft to host and penetrating keratoplasty. These can be done after practicing suturing on the suture material. And then there are green surgeries, by which I mean first case should be done under supervision, meticulous study of theory, videos, and observing many cases. Most of these surgeries have no wet lab for them as such, except LASIK. That includes chalazion, pterygium, tarsorrhaphy, PRK, and intravitreal injections. To conclude, statement 1, dry practice can be done, and it is what most of us have done. Statement 2, most institutes cannot offer a separate wet lab setup. In India, I'm not talking about international institutes, and the traffic signal theory. That means there are some steps that do definitely need a wet lab practice, but then there are others which you can go ahead with dry practice. Last but not the least, absence of a wet lab should not stop a capable resident from getting the surgical training he or she deserves. Thank you.